Good evening, everyone. My name is Bethany Yeiser. I'm president of the CURESZ Foundation. CURESZ stands for Comprehensive Understanding via Research and Education into Schizophrenia. I am delighted to introduce our distinguished guest, Henry Nasrallah, who's given his time to deliver this excellent lecture on depression this evening. Just a little bit about Dr. Nasrallah. He is a widely recognized neuropsychiatrist, educator, and researcher. Following his psychiatric residency at the University of Rochester and neuroscience fellowship at the NIH, he served for 12 years as chair of psychiatry at Ohio State and 6 years as chair at St. Louis University, followed by 4 years as associate dean. He is currently vice chair for faculty development and mentorship, professor of psychiatry, neurology, and neuroscience, medical director of neuropsychiatry program, and director of the schizophrenia program in the Department of Psychiatry and Behavioral Neuroscience at the University of Cincinnati College of Medicine. Dr. Nasrallah has published 14 books, 700 scientific articles, 600 abstracts. He is editor-in-chief of 3 scientific journals. He's a fellow of the ACNP, fellow of the American College of Psychiatrists, member of the ASCP, founder of CURESZ, distinguished fellow of the APA, and has received numerous research and teaching awards. He ranks in the top 1% of the world in terms of his publications being cited. He has received 95 research grants, and he served as president of 6 scientific societies and is listed annually in the list of best doctors in America. Welcome, Dr. Henry Nasrallah.
Thank you very much, Bethany. And I think one of the most enjoyable and important roles I play is being the co-founder with Bethany of the CURESZ Foundation, and I serve as her executive vice president and scientific director. But today I'm going to give you a very, I think, useful presentation about how to distinguish major depression, which is unipolar, people who only get depression, compared to those who have bipolar depression, those who have highs and lows, which mean they have mania and they have depression. And these depressions look alike, as you will see in the next slide. Both of them have those symptoms, sadness, low mood, crying often, anhedonia. They don't enjoy anything anymore. They give up all their favorite hobbies. This is always a bad sign when they do that. And they feel worthless, a failure, they feel stupid. And even though they are very smart, I mean, I treat people who are PhDs and MDs, and they still feel like they are worthless people. That's what depression does to your self-esteem. They also feel hopeless and helpless, and that they are beyond help, that they're doomed to forever to remain depressed. And they're very pessimistic about everything. They also have trouble sleeping, trouble eating, they lose a lot of weight, and they can't concentrate, they can't focus, or they can't remember. Their brain doesn't work anymore. Even though they're very smart, their brain stops working as well. And most importantly, they start having suicidal ideas, which means they feel it's too painful to live, it's not worth it, it's futile, dying would be a relief. So these are symptoms of depression, whether they are unipolar or bipolar. But there are quite a few differences with the bipolar depression, which I'll mention to you. And the reason this is important is because the treatment is entirely different. The medications we use for unipolar major depression is very different than those that are approved by the FDA for bipolar depression. So that is why many people with bipolar depression end up being treated wrongly, and they try this drug and that drug, and they remain depressed. And many of them commit suicide because they don't get any better. So this is a serious issue. One, the clinicians should recognize which patient actually has bipolar depression and give them the right treatment. Otherwise, they will never improve. So here are some clues to differentiate the bipolar depression from unipolar depression, which is also called major depressive disorder. Okay. We're not talking about mild depression. All of us have feel depressed 1 day or 2 days now and then for something bad happening. Major depression should be at least 2 continuous weeks of feeling down in the dumps and all those symptoms I showed you. And many times they go for months before they finally seek help because they don't recognize they're ill. They don't know that it's an illness. They think they are just, failures and it's my fault. And, they don't even think of consulting a psychiatrist until many times they make a suicide attempt, and that brings them to our attention. All right, so here are some of the clues for bipolar depression. Every clinician must ask every patient who is in front of them, coming for a history of depression, ask if there's anybody in the family who's had mania. Mania is extremely high, feeling very grandiose, very sometimes very angry. They have trouble, they're spending a lot of money. They have too much sexual, the drive, high drive. They're very impulsive. They're basically they talk very fast, and they have all the symptoms of mania. But to be diagnosed as mania rather than hypomania, which is a milder form, they should have psychotic symptoms, delusions and hallucinations, and they end up hospitalized. That's mania cannot be diagnosed unless the patient is so sick they get hospitalized for it. So ask if anybody in the family has had manic depressive illness. We also call it bipolar illness. I also tell my patients to make it easier for them. Does anybody in the family have really bad mood swings, very high at times, very low at other times? These are recognizable by family members. So if there's any blood relative in a patient's family with a history of mania, having manic episodes in the past, this patient in front of you has a very big likelihood that they also have bipolar because it's extremely genetic. It runs in the family very much so. Okay, next. Another clue that it's bipolar depression is that it starts under age 30. Most of the time, bipolar illness starts in the teenage, even in childhood. We have University of Cincinnati. We have a program for children with bipolar, 6, 7, 8 years of age. And many times their mother or father has bipolar, so it's inherited, very genetic. But most of the time, they get the first episode in teenage years or in the 20s. So whenever a patient is under age 30, it's very likely to be bipolar depression, okay? Because 90% of all bipolar individuals start their illness before age 30. And most of the time, as I said, teen years or 20s. And by the way, 70% of all people with bipolar start their illness with a depression. There's no mania yet. There's no hypomania yet. So that's what makes it so difficult sometimes to recognize that it is bipolar, because they're coming in with depression and no past history of mania. Now, here's another clue. Unipolar depression, regular depression, is 3 times more common in females. We've known this for a long time, but bipolar depression is equal. It affects males and females the same degree. So obviously, if it's a male patient, young male patient especially, that you suspect that this probably may be bipolar. You have to collect a lot of clues before you nail the diagnosis, okay? All of them are add up to the index of suspicion, as we call it. So that's another factor. Then a very important clue is the presence of psychiatric comorbidities. In the patient with depression, patients with bipolar depression have a very high rate of anxiety. We're talking about generalized anxiety, social anxiety, panic disorder, OCD, PTSD. All of those 5 anxiety disorders occur in 80% of patients with bipolar depression. So they always have anxiety with their depression, or OCD or PTSD. Also, the second highest comorbidity is alcohol and drug use. Patients with bipolar depression drink a lot of alcohol, especially when they're manic, but also when they're depressed. And they abuse drugs, especially uppers. They take amphetamine and cocaine and mushrooms, things that try to lift their mood. And also, many of them have binge eating. So they gain a lot of weight, especially when they're depressed. They crave carbohydrates. So in contrast to the unipolar depression who lose weight, by the time they come to see us, they've lost 20, 30 pounds. They have no appetite. Okay, here's the opposite. They actually eat a lot, that they binge on a lot of carbohydrates. So most of the time they're overweight or even obese by the time we see them, even before they get any treatment. We can't blame it on the medications because they're eating too much. That's part of the illness. About 40% or 50% of patients with bipolar also have ADHD, especially when they are children. They get diagnosed as ADHD because the symptoms of ADHD and attention deficit disorder, hyperactivity are common. Patients with bipolar have that too. And they get misdiagnosed as ADHD. But so many of them have both. They have bipolar and ADHD. Many studies have shown that patients with bipolar also have ADHD as a comorbidity, just like anxiety, just like alcohol, just like BED, binge eating disorder. And then finally, another important question to ask everybody with bipolar depression, whether male or female, If it's a female with children, ask her, did you get postpartum depression? And the reason this is an important question is because postpartum depression is extremely common in women who have bipolar. If it's a male patient who's in front of me, I ask them about their sister, their mother, their aunt, their grandmother, all the females in the family, if they remember if any of them had postpartum depression, because that tends to occur a lot in families with bipolar. And then there are physical comorbidities. Now, non-psychiatric medical conditions. Migraine is a good example. About 30% of patients with bipolar 1 disorder, where they have high mania, have migraine also. When they're depressed, they also have migraine. And the patients with bipolar type 2, which is a different form of bipolar, where they don't have mania, but they have small episodes of hypomania, small, mild episodes, 60% of them have migraine. So that's a clue that you can use to ask the patient, because that increases your suspicion that this may be bipolar. Also, many patients with bipolar have diabetes, hypertension, hyperlipidemia, too high cholesterol, high triglycerides, high blood pressure, and diabetes, because that tends to co-occur biologically. It kind of runs in the same time in the body of people with bipolar. They have both medical illness and mental illness at the same time. That doesn't happen that much with unipolar. Now, the other clue is, remember I told you about unipolar, they don't eat much, they have no appetite, food tastes like cardboard, so they stop eating and they lose weight. Patients with bipolar disorder have the opposite. They eat a lot, like I told you, they crave food, but their sleep is also different. Patients with unipolar, they have insomnia. They come begging us for sleeping pill because they cannot sleep. Patients with bipolar depression sleep too much. They sleep 11, 12 hours a day. They can't get out of bed in the morning and they miss work. They're late to school, things like that. So it's the opposite. Too much food and too much sleep in the bipolar, too little food and too little sleep in the unipolar. So that's another distinguishing feature. Another thing that is a clue when patients are referred to our clinic. I mean, I run a mood clinic with the residents and train them there. Many patients are referred to us from the community by their family physician or by their psychiatrist saying, please take this patient. They have treatment-resistant depression. They don't respond to anything. And when we look into their record, we found that they have tried 5, 6, 7 different antidepressants with no improvement or even worsening, because they're giving them the medications that are approved for major depression, the unipolar, which are not approved for bipolar. So no wonder they don't respond. So a history of multiple failures over months and years sometimes is another clue that they are probably bipolar. They should be receiving one of the drugs that are approved by the FDA, and there's only 4 of them. Okay, but we have like 24 drugs that are approved for major depression. It's a mistake. That's the problem. They make a mistake by diagnosing the patient as unipolar when they're bipolar, and they give them treatment with good intentions. They give them medications that are for unipolar, but the diagnosis is wrong. If the diagnosis is wrong, the treatment is going to be wrong. This is why it's so important to have a very good clinician examining people with depression, because suicide is a very high risk. 20% of people with bipolar die of suicide. I mean, this is horrible. They don't get treatment in time, delay of treatment, wrong diagnosis. They don't get the right treatment. They make attempts, and many of them die. Not all of them, are treatable when they make a suicide attempt. Next are the psychotic symptoms. Whenever you have somebody with depression, but also have delusions or hallucinations, and we always ask that question, and every patient who comes to psychiatrists, we have routinely asked them, do you sometimes hear voices? Do you sometimes see things? Do you have like paranoid ideas, people plotting against you? Or do you have like unusual thoughts that, people told you are really unusual? That's delusions, fixed false beliefs. Patients with depression who have psychotic symptoms are probably bipolar, because bipolar disorder is a psychotic disorder. Major depression is a mood disorder. Okay, so they both have mood symptoms, but one of them is really a psychotic disorder with mood features. The other one is pure mood disorder. So that's another clue that you can ask about. Also, the onset of the depression tends to be very slow in patients with unipolar. It takes them months and months before they come to seek help. it gradually gets worse and worse. Patients with bipolar depression can get depressed like extremely bad within 2 weeks, and the spouse or the partner, who brings them to our care, say he was perfectly fine until a couple of weeks ago, and then he decided life is not worth living. He was crying all the time, staying in his room, stopped working, and stopped doing anything fun. I mean, this can happen like quickly. That's very common in bipolar. It doesn't happen that way. Unipolar is much slower, insidious, we call it. Okay. And then, every patient with depression should be asked those questions. This is for bipolar type 2. Okay. Mania, bipolar type 1 is you can't miss it because they've been psychotic, they cannot work, and they get hospitalized. That's severe mania. Okay. But there's a subtype of bipolar which is milder. They get depression all the time. But in between, they have tiny days, 3-4 days when they feel much better. So these are the symptoms they have. We have to ask the patient because they don't tell us this. They don't realize that this is an episode of hypomania, we call it. So we should always ask patients with depression, do you sometimes have like 3-4 days when you feel much better than usual, a lot of energy, your thoughts start racing, which is a manic symptom, a lot of ideas bubbling in your head. You start spending more money than you should, and you start having more sex than you did when you're depressed. People with depression don't have sex; they just don't. It's gone during depression, and episodes of irritability, which is very common in bipolar people. It can be very anger. It can be like you kill people. People who have mania, the full-fledged, very severe mania, can commit crimes. They end up in prison, actually. Hypomania, they get irritable, angry, edgy, cranky. So you have to ask them, do you sometimes have those that come and go episodes for no reason at all? You feel irritable? That's a clue that they are not just regular major depression. This is bipolar depression type 2. Okay, which can be easily missed because all they have is depression after depression after depression, and they don't tell you that they have episodes now and then of increase, a little bit hypomania. Another thing that is very typical of people with bipolar is that they're very talented people. They write very well. They are authors. They're poets. They're painters. They are musical geniuses sometimes. They're really great in music, composing and singing and so on. They have leadership skills that makes them, go up the ladder in a company. They become directors or, vice presidents and stuff like that. And they're very eloquent. They speak in a very, eloquent way. Their use of vocabulary is very much better than normal people. And they tend to be charismatic. They're easy to like. They're gregarious. They like to mix with people. So these are the personalities of people with bipolar when they're depressed or when they're not depressed. This is something they're born with. They tend to be very creative. Some of the most famous musicians uh, create the best symphonies in the world when they are hypomanic. Like Handel, he wrote the Messiah, is a masterpiece, the Messiah. He wrote it in 2 weeks when he was in a hypomanic phase. And then when he got depressed, he went for months without making any music. Okay, so depression can take away your energy to produce, to write, to make music, to paint, etc., which is a pity because many of them are talented when they're not depressed. I'm going to give you some examples of famous people you might recognize who had bipolar disorder and bipolar depression. Dylan Thomas, famous singer, right? Edgar Allan Poe, famous writer. Ernest Hemingway won the Nobel Prize for his books. Eugene O'Neill, another famous writer. Lord Byron, Herman Hesse, John Keats, famous poet. Virginia Woolf, again, she's a very, very famous writer. Hans Andersen, Christian Andersen, Leo Tolstoy, who wrote War and Peace. I mean, these are people, shows you they're famous people who had bipolar. Fortunately, they didn't kill themselves, but they managed to remain like on a low scale of bipolar. And then you have, Saint Millay, Saint Edna Saint Vincent Millay, Ralph Waldo Emerson, Samuel Clemens. Sylvia Plath killed herself. She was a famous poet. She had bipolar depression and killed herself, suicide. Which is unfortunate. She died young. T.S. Eliot, another famous writer who also was bipolar. Victor Hugo, a famous French writer. Tennessee Williams, Art Buchwald, Kathy Cronkite, Pat Conroy. You remember many of those people. You may have read their books. But also there's composers and musicians like Cole Porter, Peter Tchaikovsky, very famous musician. Irving Berlin, my God, we all know his musical compositions. Beethoven, who doesn't know Beethoven? Handel, I just mentioned him. He wrote The Messiah. Jimi Hendrix, a famous singer, who again died prematurely. Brian Wilson from the Beach Boys. He had schizoaffective bipolar type. Was very creative. All the songs of the Beach Boys were written by him, and the music was composed by him. Judy Collins, James Taylor, again a famous musician. Political figures. Abraham Lincoln is believed to have had bipolar. Okay, clearly on a mild scale. So, but he had depressions, but he was fantastic when he was not depressed. Winston Churchill, he saved England in World War II. Thomas Eagleton, who ran for president in the United States in the 70s, but because he had a history of taking ECT for his depression, and he was perfectly normal politician, he was a senator, they discriminated against him, and he had to withdraw from running for president because of a history of bipolar. Unfortunately, we still have that stigma that we need to erase in this society about mental illness. Kitty Dukakis, also the wife of Dukakis, who ran for president and didn't make it, but she came public, talked about her depression as well. Lionel Aldridge is an athlete. Isaac Newton, who is believed to have the highest IQ in the history of mankind. He had an IQ of 200. He's the one who discovered gravity. He was bipolar. See how creative these bipolar people are? So we should have to remember that, yes, sometimes, oftentimes they get depressed, but when they're not depressed, they are ingenious. They create, do things, all kinds of things. So another thing that is typical of bipolar individuals, even though they're depressed when they come to see us, ask them, have you ever started a business? You'd be surprised how many bipolars actually have this energy, creative energy. They start their own business, and many times they get very successful. But then when they get depressed, they go bankrupt because they mismanage the business. They start another business. So many business people, successful business people, actually have a touch of bipolar in them. Okay. Also, it's useful to ask patients with depression, do you like to gamble? That's a clue that they're probably bipolar, because bipolar disorder, they love to gamble. And even though they're depressed in front of us, when they are not depressed, when they're hypomanic or manic, they gamble. They love car racing. They also ask them, do you ever date 3-4 people at the same time? That is very common, or excessive masturbation. These are typical of people they have so much sex drive. They like to date multiple people of the opposite sex, usually. And so that's a clue. Even though they're depressed, when they're not depressed, they tend to have hypersexuality. Also, ask them about their job history. So patients with bipolar, many times, if you ask them, you find out that they either got fired or quit for many little jobs that last 2-3 months, and they quit or go to another job, or they get fired because they're rude to the boss, they get irritable, or they get impulsive. They make very stupid decisions that they regret later, but that's part of bipolar. They can't help it. They get very impulsive. That shows itself in jumping from job to job. Okay, they don't settle down. Another thing that's also interesting, we ask, have you ever been married and divorced 2 or 3 times? That is very common in people with bipolar, but not in major depression, the unipolar, who rarely, get married maybe once if they're lucky. But bipolar patients, they fall in love, infatuation, and then they regret it, they divorce, they marry another person, they fell in and out of love a lot. Plus, the sex drive makes them do that as well. Now, also look at the patient. We notice that patients with bipolar depression tend to wear very colorful clothing, red and pink and green, and garish, very colorful blouses or dresses or shoes even, because people with bipolar love colorful things, and they buy their clothes when they're hypomanic and they have money to spend and they like to spend money, so they buy colorful clothing. But now they're coming to us with depression wearing the clothes that they bought when they were high, when they were bipolar. So that's another clue for bipolar depression. So when you add up all of those clues together, you increase the risk, you increase the chances that you are really dealing with a bipolar in depression, not unipolar. You take time. This takes time to ask. And many clinicians are too busy and they say, I don't have time to ask all those questions. But you have to. If you don't, you end up with the wrong diagnosis, and the wrong diagnosis leads to wrong treatment. They did a survey of 1,500 people with bipolar disorder, and it was published a few years ago. Now they have bipolar. They're well diagnosed. They asked them, how long did it take from the onset of your first symptoms until you got the diagnosis of bipolar? How long did it take? 8 years. Imagine going, can you imagine somebody with heart disease or cancer going for 8 years before they're diagnosed? They would die. And same thing with bipolar. By delaying that, because during those 8 years, they were diagnosed, oh, you have anxiety. Oh, you have alcoholism. Oh, you have borderline personality. Oh, you have major depression. You have ADHD. They give them the wrong diagnosis, which means the wrong treatment, and many of them die because the depression leads to suicide. This is why it's so unfair that patients coming in with a depression symptom of depression bothering them must undergo a careful interview where you cover all of these bases, not just the first 9 symptoms I showed you at the beginning. All of depressed people have those symptoms, but in addition, bipolar patients have all these additional attributes that will make the clinician basically realize they're dealing with a bipolar patient. So thank you very much for listening to me in many languages here. And it's time for you to ask me questions for anything that you like related to depression and bipolar, or anything related to what I talked about. And please, when you do, you have to unmute yourself and raise your voice so I can hear you well.
Thank you, Dr. Nasrallah. That was an excellent lecture, and we appreciate you. We have a couple of things in the chat from Chelsea. I think I'll just read what she wrote. When I was in a state mental institution, I wrote over 30 songs with piano music. I wrote a PhD thesis on the necessity of moderation in all areas of life. I created many ideas for research projects. I have a notebook with over 30 ideas. On my unit, they put up chalkboards on the unit, and I spent days working on triple integral problems I came up with. So, case in point. Thank you, Chelsea.
Absolutely. I mean, these are all the stigmata of bipolar. All this excess creativity, ability to conceptualize and write and create. That I told Chelsea before we started that based on, and now she's working on a PhD at Princeton. Clearly, Chelsea had
Hoping to. She's
bipolar.
trying, hoping she'll get in there.
But the reason Chelsea was misdiagnosed and treated wrongly for several years is because she had psychotic symptoms. And about 55-60% of patients with bipolar have psychotic symptoms. So immediately the clinicians rushes to the diagnosis of schizophrenia. And they give them antipsychotics instead of giving them mood stabilizers. Now, Chelsea, how old were you when you were when you had your first episode?
I was 16. I was suicidal. I went to the hospital in 2005, and I was diagnosed with possible bipolar.
Okay, so somebody did that diagnosis of bipolar. And like you said, the 70% of people with bipolar start their illness with depression and suicidal act. That's typical. So, but unfortunately, you went for several years without good, solid treatment that stabilizes you, and you could have, finished your degree by now. But I'm so thankful that you are finally on the right track. When did you receive clozapine? At what age?
About 4.5 years ago.
4.5 years after the onset?
No, 4.5 years ago.
Ago.
2005 to 2021.
Yeah. So before clozapine, you were treated with all kind of drugs that didn't work or made you worse sometimes. A lot of side effects.
I was on a lot of. I basically tried all the antipsychotics. I tried a lot of the antidepressants, but the antidepressants would make me very, very, very manic. So I would be like catatonic for a few days. They would give me Ativan and then antidepressants, and then I'd be like really like energetic. So I would go from catatonic to energetic, and they were like, "How is she going? Like, how is there such a quick reaction?" And I couldn't explain it to them.
Exactly. Yeah. That what you said is so true. And we call it antidepressant induced mania. Switching to mania is one of the consequences of giving people with bipolar, Prozac, Zoloft, Paxil, Effexor, the drugs that are good for unipolar. But if you give them to somebody bipolar by mistake, thinking that they have unipolar, they end up switching. 4 bad things can happen: switch to mania, switch to hypomania, switch to a mixed state when you are depressed and angry at the same time, and mix and switch to rapid cycling. You can you get depression after depression after depression. Like it looks like non-remitting depression. So these are all consequences of the wrong treatment. And Chelsea unfortunately experienced some of that. But many patients come to us in the clinic with such a history. It's so easy to treat people with bipolar. Once you make the right diagnosis and you give them the right treatment, they go back to their normal life and they function. They function beautifully because they're so talented.
I would, just to say something really quickly, I would love to have a way of watching or scanning the brain to actually see the levels of the neurotransmitters like throughout the brain. Not only like how active the areas in the brain are, but also how like track how all the neurotransmitters are work throughout the brain, because I feel like
Yes.
that would give us a lot. And instead of just like handing out medications and doing trial and error, we would just like scan your brain and see how, oh, that's the exact medication you need, you know? Yeah.
Yes, many neurotransmitters are involved in mania. The most active one is dopamine. When you get too much dopamine, and you get manic. You know, it's also involved in schizophrenia, by the way. But mania have it in a different part of the brain, and it gives you all this energy and thoughts and racing ideas and fast talking and increased pleasure, because dopamine is the pleasure neurotransmitter. That's why they get hypersexual driven, a lot of libido, and all of these symptoms. But they also have GABA and serotonin and glutamate. They also play a role, the major neurotransmitters that you mentioned.
Okay, we have a lot of questions in the chat.
Oh, let me look at the chat then. I'd love to read them. What is the chat box
If
here?
you like, I can read the next one.
Go ahead and read it.
Okay. What do you think causes depression to transition into bipolar disorder?
What can cause depression? Read that again.
Sure. What do you think causes depression to transition into bipolar disorder?
Oh, if they are bipolar disorder and you give them an antidepressant, antidepressants increase dopamine, increase serotonin, and increase norepinephrine, which are the neurotransmitters I was telling Chelsea are involved in mania. So this is why, but it doesn't happen with people with regular depression. We give them antidepressants that increase what you call the monoamines, dopamine, norepinephrine, serotonin. But increase them in regular depression, that's helpful. It's therapeutic. They get out of depression. But if you give them people with bipolar, thinking that they have regular, major depression, it pushes them to the other side. It swings them to switch them to the high side. That is basically a chemical switch. That's why that happens.
Why do you think bipolar patients love colors?
Because they are very creative people. They love colorful things. They love drawing. They like art in general. They tend to be stimulated. Their brain is stimulated with a lot of things. Clothing is being part of it, but they do that everyday life as well.
Okay. If you have unipolar depression and have tried a host of medications with none helping, what should one do?
Well, you better get a good evaluation by an expert in mood disorders to rule out the possibility that you have bipolar depression, not unipolar, because you fail multiple antidepressants. That's a clue. But in addition, there is a category called treatment-resistant depression, which is not bipolar depression. It's just regular depression that doesn't respond to anything. It's a subgroup of patients like that, and they respond very well to ECT. Let me make a plug here for what's called shock treatments, which is a shocking term, of course, but we call it electroconvulsive therapy, ECT. Neuromodulation is another term for it. It's one of the most wonderful treatments in the world for people with depression. 90% of people who don't respond to medications will respond to ECT, and we use it for bipolar too. Patients with severe bipolar who don't respond well to many medications, we give them ECT and they stabilize very, very well. So ECT
Doctor,
actually. Go ahead.
Can I jump in here because it is very specific to this?
Yes.
My son has treatment-resistant depression. He also has severe OCD and many other diagnoses, and
yes.
he's been on like 30 medications. Nothing helped. He has also had 2 rounds of ECT. And when he was receiving ECT 3 times a week, you could see a huge shift in his mood.
Improvement,
But-
you mean? Improvement?
Improvement,
Yes.
yes. But that's not sustainable 3 times a week.
But you know what,
ECT.
Robin, we no longer stop the ECT. It's like medications. You know how we treat medications initially with high doses, and then we give maintenance treatment. They have to continue taking medication.
As soon as he went down to maintenance, nothing. He went right back into severe depression.
No, let me make sure you understand what I'm saying. After we do a couple of weeks or 3 weeks, 3 times a week usually we give 9 treatments, 3 a week for 3 weeks, and the patients get out of their depression very well. We don't stop there. We actually continue doing 1 ECT every 2 weeks for like 3-4 months, and then we go to 1 ECT every month. That's maintenance therapy. He did not respond to that?
As soon as they went down from the 3 times a week to the 2 times a week, and then to completely, his mood went back.
His symptoms went back. So did anything work for him, or is he disabled?
Nothing works.
So what's he doing now?
He's functioning not very well. Severely
Functioning
depressed.
meaning what? He has a job?
He works 2 days a week.
That's great. So he is functioning. He's not, people with severe depression don't function. By definition, they are unable to function. But has he ever been given ketamine?
Yes, nothing.
Didn't happen. Did they get it intravenously or by sniffing, by the nose?
Intravenously.
Okay.
Yeah, intravenous.
Okay.
He's also had 2 rounds of TMS.
He has TMS.
So-
Yeah, ECT is actually works better than TMS in general.
Yeah.
But there's another treatment that's very, very powerful, approved by the FDA. It's called VNS, vagal nerve stimulation. So the neurosurgeon will install a stimulator in their neck that is next to the vagus nerve. And over time, we discovered that by accident, actually. People with epilepsy for whom this treatment is given, the vagal nerve stimulation is given for severe epilepsy. They discovered that whenever they did that for people with epilepsy who had depression, their depression improved along with the epilepsy. So they did clinical trials, and it's approved by the FDA. Okay, so that's another option. Deep brain stimulation is another option. There are many studies where you insert a very thin electrode, with MRI scan. You can tell where the electrode is going, and there's an area in the frontal lobe here called subgenual area 25, Brodmann area 25, which is small in patients with depression. When you stimulate that, there's remarkable improvement for treatment-resistant depression. So don't give up on your son. I mean, I'm glad he's functioning.
No, I'm not giving up. I'm kind of relentless. Sticking something in his brain is a little scary.
Yes, I didn't mean giving up on him. I meant don't give up on the possibility that he can recover, but he has to be treated by an expert in treatment-resistant depression. Okay, there are people like that around the country. Where do you live?
I'm in California, and we're with UCLA. So he's got pretty. But if you have any,
they have great people at UCLA. But one of the best treatments are being done at UCSD in San Diego. An hour and a half down from where you live. They reported incredible results, and also at Stanford, north of you, they're doing very specific type of theta stimulation. They do like 5 treatments a week, and there's incredible response.
That's the TMS.
Now that's TMS, but I'm talking about Saint. Saint is different than TMS. It's really a very different treatment that's been published and is very promising. So again, you can certainly make an appointment and do it. San Diego has a group that does that. Stanford has a group that does that. At UCLA also they have a group, and I can find out for you who the main person is, because I have friends and at UCLA who can tell me who is doing that for severe depression, and I can send you the name.
That would be wonderful. I'll take
and
anything.
USC too. And USC has very good people.
Okay.
Great. Thank you.
4 medications approved by FDA to treat bipolar. Now, Maureen has written in that they are lithium, carbamazepine, divalproex, and lamotrigine. Would you like to expand on that, doctor?
I'm glad she asked that question. Okay. let me tell you the truth about bipolar depression. None of the ones you just mentioned actually works in bipolar depression. They work in mania, okay? But and not all of them. Lamictal, lamotrigine, does not work in either mania or depression, okay? But it is given when people are no longer depressed for maintenance therapy. Now, lithium is a wonderful drug. It's a natural salt. It came to the US in 1971, and definitely one of the best treatments for mania. We have very, it has some side effects, but it's very, very widely used. Valproate Depakote is an anticonvulsant for epilepsy that again was noticed to help depression in people with epilepsy. So they did clinical trials in 1992 with a company called Abbott, and it worked. It worked very well with high doses, and so FDA approved it for mania. This is not for depression. It was approved for mania. There's no evidence that it works for depression. Now, carbamazepine, called Tegretol, also was used initially in Japan in the 80s and then came to the United States, and it works very well in bipolar mania, but not in depression. And we don't use it anymore because it makes the liver produce so many enzymes that chop up all the other drugs, so the blood level goes down. It's very bad. I never use it anymore, but it works very well in very angry, hostile, manic patients. It reduces their anger. All of these things that you mentioned are manic, anti-manic. For bipolar depression, the 4 drugs I told you are approved by the FDA are none of those. And every patient with bipolar must receive one of those drugs for depression. They get it in addition to lithium, in addition to Depakote, they should get one of those 4 drugs. All 4 of them are atypical antipsychotics. They were initially approved for schizophrenia, and the companies noticed that they seem to help mood. So they did the clinical trials for the FDA in bipolar depression, and they worked. So the 4 are Seroquel, quetiapine. It came out in 2005. It was the first one. Second was lurasidone, called Latuda, the trade name, came out in 2013. And then Vraylar, which was approved by, I've done the clinical trials with all of them, by the way. I did the FDA studies with all of them. And Vraylar, or cariprazine, initially approved for schizophrenia, again was found to help mood and was approved by the FDA because they did it in bipolar patients. You have to do a different study with different patients to get it approved. But all of them work in schizophrenia. They're all antipsychotic. So don't be surprised that the 4 antipsychotics are approved for bipolar depression, because like I told you earlier, bipolar depression is a psychotic disorder. Okay, so bipolar disorder in general, mania or depression, have psychotic features. So the atypical antipsychotics work. The last one was launched in 2020, and it's called lumateperone. The trade name is Caplyta. Okay, so now we have those 4. All of them are useful. You can use any one of them you like. And what's nice is that some patients respond to one better than the other with fewer side effects. Seroquel, which was the first one, causes some weight gain and excessive sedation and increased cholesterol, so I don't use it anymore. We used it when it was the only one. We were happy. Finally, a drug was approved after decades. We have nothing approved for bipolar depression until 2005. But then when Latuda came and Vraylar came, they have very little weight gain, and they're better, more tolerated. They're not as sedating. So that's why we like to use those first. Okay, and if they don't work, then you go to an algorithm. You use the Caplyta is a good drug also. Caplyta has no weight gain and no EPS, no sexual side effects from prolactin. I mean, it is very, very clean drug. So again, that's something that many people like to use, because especially if they're already overweight. Bipolar patients with depression tend to be overweight. You don't want to give them a drug that makes them gain more weight. So I consider that an important factor when I select the medication for the patient.
How do you?
Bethany,
Okay.
this is Dr. Amber Irwin. Would I have a quick second to ask a question of Dr. Nasrallah?
Sure.
Go ahead.
Hi, Dr. Nasrallah. This is
Hi,
Amber Irwin. It's great to meet you virtually. I've heard so much about you through Bethany, and I actually teach nursing at the College of Nursing at University of Cincinnati, and I'm a psych nurse practitioner. And
Wonderful.
I would like, first off, if you wouldn't care, I don't know if you mind to share your slides with us. that would be wonderful if you don't mind.
I'd be
Number
happy to.
two, a question I have for you. In my Okay, thank you. A question that I have, I treat a lot of children, and in my program, they taught us that we'd be reluctant to diagnose children with bipolar. Can you give me your opinion on that? And then after you, what medications do you find useful to treat children with bipolar?
Okay, good question. It's a mistake and misinformation that you cannot diagnose the bipolar in children. Bipolar disorder starts around age 3, 4, and 5. If the mother or the father, or many times the mother and father are both bipolar, it happens very early. In fact, there is also evidence that in the families of bipolar, let's say the grandfather starts the illness at age 25, the daughter starts the illness at 18, and the grandchild starts the illness at 7. So with every generation, the onset is earlier and earlier. It's called genetic anticipation. That's the technical term. So that's number one. It is absolutely wrong to assume that you cannot diagnose it in children. And many of them are misdiagnosed as ADHD, but some of them have both ADHD and bipolar. That's why, but they go to the pediatrician, and many pediatricians have no idea how to diagnose bipolar. They just focus on ADHD. The second question, part of your question, is treatment. And this is true in the United States. We have very, very few treatments available for children under age 12. Okay, pre-puberty. Very few. The companies don't do clinical trials, but there are some that do it in adolescence between 13 to 18. Of those 4 that I mentioned to you, Latuda, lurasidone, is actually approved by the FDA for adolescents because the company did the clinical trials. So if you have an adolescent between age 12 to 18 with bipolar, you heard Chelsea just said that her illness started at age 16. Okay, that for if she was depressed, and if Latuda was available at the time, that would have been the choice for her, because they did the clinical trial. Doesn't mean the others don't work. It means they haven't done the trial. Companies have to spend millions of dollars to do clinical trials and show the FDA that it works, and then it gets approved. So they usually get all the clinical trials for the FDA are between age 18 to 70. That's how they start the clinical trials in adults, 18 to 20. They rarely put any children or adolescents until later. Some companies decide, okay, let's give it a shot. And FDA rewards them. If they do clinical trial in adolescents, they give them an extension for their patent. Okay, so it expires a little longer. So, and to answer your question, there are a lot of child psychiatrists who are using drugs off-label for children with bipolar or bipolar depression, and including lithium. I mean, they give lithium to kids who have bipolar at age 7 or 8 because it does work, even though there's no official approval for it. It is unfortunate that we don't have. They're risk averse. They don't want to do clinical trials in children and risk that somebody dies. Then the whole company will go bankrupt, because one kid died in the clinical trials. That's why they tend not to use it.
Okay.
Thank you very much.
You're welcome.
Thank you, Dr. Irwin. How do you deal with people who are manic? Help them besides medication?
How you treat mania?
Besides medication.
Besides medication? Well, they cannot treat mania with psychotherapy. Okay, we do use psychotherapy in addition to medication. It's absolutely useful. We always do psychotherapy, but the medication stabilizes the brain so that they can use psychotherapy. ECT is also very useful. Non-medication, okay, but many patients don't want to have it. They're scared when you tell them it's ECT. Oh my God, shock treatment! I'm going to go to convulsion. It's the most safest drug. They don't even move a muscle. They call it electroconvulsive therapy because we paralyze them with a medication for like 10 minutes. Their body is completely paralyzed. So when they get the seizure, only it happens in the brain, but the body doesn't shake at all. So but most people don't know that. So patients with mania, by the way, they tend to like being high. It's the karma. They feel so productive. They're so energetic, so great. They get, euphoria, but it's so dangerous for their brain because many times they end up become dysfunctional or become angry. 50% of patients with bipolar become extremely angry and aggressive, and they kill people. and they go to prison and they serve sentences. They're all in the jails and prisons of this country. There are many people who were bipolar and committed their crime. I went to death row once and I consulted on a very nice man who did very well, but then stopped his medication and took a cocaine and murdered 5 people in a frenzy of mania because induced by cocaine, and he was sentenced to death because of that. So even though he was perfectly normal and healthy for several years in death row in the prison, the guards loved him, but it's too late. They committed the crime when they were in a manic stage. So it's really important for people with mania to receive the treatment, even though they refuse it. They have anosognosia, like schizophrenia. They do not believe they're sick. During mania, they have no insight. How can I be sick? I feel better than ever. But it's actually a very severe illness. But when they get depressed, they recognize that they're depressed. They come begging for help. Please help me. I feel so depressed and so on. But during the manic phase, they refuse it. So to your question, we must use medications. We must use medications, sometimes against their will, especially if they're a danger to themselves and others. Antipsychotics, there's several atypical antipsychotics like risperidone, olanzapine, aripiprazole, geodon, iloperidone, paliperidone. They're all approved for mania in addition to schizophrenia. So they work on mania because they reduce dopamine activity. Okay, but in addition, you could certainly use lithium and Depakote because they are anti-manic without having the antipsychotic effect. So if the patient doesn't have psychotic symptoms, I would give them lithium or Depakote. But if they have psychotic symptoms, which, as I said, is 55, 60% do, then giving them an antipsychotic makes sense. And for everything, if everything fails, clozapine is the best treatment for treatment-resistant schizophrenia and treatment-resistant bipolar disorder. Okay, there are 8 studies showing that it works in bipolar, but although it's not approved by the FDA, but academic psychiatrists did studies, and they're all published. It works in 80% of people with very refractory bipolar, but also works in schizophrenia. That's why FDA approved it for that, and for suicide as well. Patients with schizophrenia tend to have a lot of suicidal ideas. Clozapine is the best treatment for those people.
We have about 6 minutes left, so let's just
Yes.
keep going. Is Wellbutrin wrong for bipolar?
They used Wellbutrin before 2005, as I told you. That's the year when we had the first bipolar depression treatment, Seroquel. During the 80s and the 90s, Wellbutrin was introduced to the market in 1985, okay, as an antidepressant. And it is different than the others because it doesn't have any serotonin activity. And they found out, like clinicians said, when I use Wellbutrin in patients with bipolar depression, they don't switch as much as they do when you give them one of the other drugs. Okay, so a lot of people started adopting it because there was nothing approved for bipolar depression. But once we started having those 4, since 2005, we have 4 of them now on the market. I mentioned their name to you. That we use those instead of Wellbutrin. We don't use Wellbutrin anymore.
Okay. From Sylvia, my son was diagnosed with schizoaffective disorder and depression. He takes clozapine and Seroquel to help him sleep. He shows signs of depression and social anxiety. He rarely leaves the house. Should we ask the psychiatrist to give him an antidepressant?
Well, he's taking clozapine for his bipolar mania, I assume. He has some psychotic features, schizoaffective. I don't understand why they give him Seroquel, a small dose. Seroquel is an antidepressant for bipolar, but in order for it to work, it has to be given around a dose of 300 milligrams a day. Most people, what you said, Bethany, you read the question, it's given for him to help him sleep. Why do you need medication to help you sleep? Clozapine is the most sedating antipsychotic in the world. And Bethany knows that because she got so sleepy when she started taking clozapine, many years ago. And so if they want to treat his depression, and he's definitely schizoaffective bipolar type, then you have to give him at least 300 of Seroquel at night every day with the clozapine. Okay, or because it causes weight gain, like clozapine causes weight gain too, and you don't want to give Seroquel for patients who already have weight gain because it makes it worse, and it's already sedating. Clozapine is sedating. Why add a sedating drug? I would give him one of the other 3, either lurasidone, Vraylar, or Caplyta, because those are antidepressants that don't cause weight gain and they don't cause sedation. So you try to give the patient a mix of drugs that make sense, that are therapeutic, without side effects.
Okay, see how much time we have. My son took antidepressants 2 separate times for depression and manic episodes came out in him. However, he was diagnosed with bipolar. I always wondered if he was misdiagnosed because he did well with his first antidepressant. Second time he took some Zoloft, his sister's med, and he came off with much mania, pressured speech. He called an ambulance and then it went to a psychiatrist who diagnosed bipolar.
Yes, whenever you develop manic symptoms with an antidepressant, change the diagnosis immediately to bipolar. It's no longer, they were given this medication, Zoloft or whatever medication. If it causes manic symptoms, you stop that and you give them one of the 4 I mentioned. In fact, not only one of the 4 for depression, you got to give them lithium or Depakote or one of the antipsychotics approved by the FDA for mania. You have to take one of those. And you have to give them one of the 4 antidepressants. Every single patient with bipolar disorder is going to get depressed, whether you like it or not. Even when their mania is controlled with lithium and Depakote, which have never been approved for depression, they're just approved for mania. So every patient with bipolar should receive 2 drugs, one for mania and one for depression. Okay, that's how you stabilize them.
I think we have time for one more question and then we'll close out. Maureen says, my son has schizophrenia and severe depression. He has none of the signs of bipolar. They recently put him on lithium. It has been 6 weeks with no uptick in mood. If you don't have bipolar, is lithium the wrong medicine? Any suggestion on a different one?
Yes, there are a lot of patients who have schizoaffective depressed type. They're not manic. They're not bipolar. There's a schizoaffective bipolar type, and there's schizoaffective depressed type. For those patients, like this patient you just told me about, you can give them a regular antidepressant. Okay, SSRIs, work very well. Make sure it doesn't interact, drug-drug interaction. You have to understand. Physicians know that some drugs can interfere with the metabolism of the anti-manic drug. So you can of the antipsychotic in this case. You can give them any one of the existing antidepressants on the market if they're not bipolar, along with the antipsychotic for the schizophrenia. That's not an unusual combination at all.
Okay. Thank you, Dr. Nasrallah. We will
My
close out
pleasure.
here.
Thank you.
We appreciate you, your time and your commitment and your expertise.
My pleasure.
night,
Bethany, I'm going to
everyone.
send you the deck and you can share it with especially clinicians who need to read it. But if families want it as well, that's fine, so that they can learn and can remember what we talked about today.
Thank you. I'll
You're
look
most
forward to
welcome.
receiving it. Good night.
Good night, everybody. Thank you.